Hole-surgery, again, until recently was thought to be untreatable. But it was the realization that these aren't actually pieces of tissue that are missing, but just being pulled apart by so-called tangential traction that allowed for treatments to be developed. And this is a case of a macular hole. A green dye has been instilled, which allows one to detect the traction that's being caused. And you'll see this is a flexible diamond-studded little instrument, which allows us to peel this very, very thin layer of tissue off the surface of the retina. You'll see it eventually go 360 degrees around the hole. And by peeling this off, we're relieving that traction that's pulling open the hole, so that after, postoperatively, that hole will close and disappear. As it's peeled off, the tissue scrolls up and is removed basically in one large sheet. Out, and you can see now there's this circular area that's been peeled off, and that hole now is no longer being pulled upon. At the end of these operations, the eye is filled with a gas bubble, and the hard part about it for the patient is for a week now we ask patients to lay on their face as much as possible, because by lying on your face, that bubble that's in the eye rises up and pushes and seals where the hole is, and that's what helps the edges come together. That's the hardest part. Surgery's not so bad. And this is a pre- and post-op picture. That's pre-op with that macular hole, and post-op, the hole is virtually gone. You know, if one were to ultrastructurally look, there'd be a little line there where those edges have come together, but for all intents and purposes, the hole has disappeared. The other really nice thing about this OCT is it allows us to show patients what their problem is. It allows them to really see and understand very clearly, preoperatively and postoperatively, what's going on. This is a case of an impending macular hole, like we were talking about, where that vitreous is adherent to and lifting up and creating a little tent. This is actually an employee here in the hospital. She came in, her vision wasn't terrible. It was about 20/80, but she complained that everything was looking distorted and things didn't look right, and her vision was down. Truthfully, when I looked in, I couldn't see anything. I didn't know what the explanation was, but the OCT immediately explained what was going on. So surgically, one just had to go in and peel that stuff off, and postoperatively, the normal appearance has been restored, and her vision's back to normal, and she should never have that problem again. Again, because the vitreous doesn't form itself over again, it'll never come back, and the problem can be solved. Subfoveal surgery is very interesting. The subfoveal space, meaning the space underneath the retina, was long thought to be this pristine, impenetrable place where we couldn't put instruments, and it was thought to be untouchable. But about 10 years ago, people started exploring actually making little incisions in the retina and reaching underneath and removing abnormalities underneath the retina. And it, of course, opened up a whole new frontier of procedures for problems that prior we never had dealt with. And this is a patient, actually, it's the only time I've ever operated on a friend of mine, but it's a long story. But it's a friend of mine, and he had been told for years that there was nothing to do. He had this big scar underneath his central retina. But what was done here was a little cut was made in the retina, a little injection of fluid is made to create a little blister so that we have space to work. And then you'll see in a moment, with a little pick, I'll kind of mobilize that scar from underneath the retina, and then with some little forceps, we'll pull that scar out. So these instruments are going through a hole in the retina, underneath the retina, reaching this scar that had formed. And you can see that scar being peeled off from the structures under the retina. Once it's been sufficiently mobilized, because you can imagine these are all structures with a lot of blood. If you just yank on something that's very adherent, it'll create bleeding and bad complications. But now that it's mobilized, one can reach in and pull this thing out. And as you can see, the retina underneath it actually looks very normal, and he luckily got restoration of normal vision after the scar was taken out. With this little vitrectomy machine, the scar will just be removed. And at the end of the operation, again, it's filled with a gas bubble, just so that that little cut that we made in the retina will heal. This is a complicated retinal detachment, meaning you can see that's detached abnormal retina. That folded up white tissue. The retina is not flat against the inside wall of the retina, of the eye, but it's been lifted off. So vitrectomy is done to remove all the vitreous, to remove all the scarring that's tugging on it. And now this heavier than water liquid perfluorocarbon is being injected, and one can see as a steam, like a steamroller, it pushes on the retina and flattens it against the wall of the eye, reattaching the retina. And now with laser, once the retina has been pushed back into place, with laser we essentially spot weld it down to tack it to the wall of the eye to make it stay there. And these are all techniques that just a few years ago didn't exist. Most retinal detachments like this we just couldn't fix. Partly because we didn't have techniques like these heavy liquids to flatten the retina against the wall of the eye, but we also didn't have visualization systems like we have now, allowing us to see way out into the peripheral parts of the eye, which now we can, and we can see very well. And obviously the key to repairing anything is first being able to visualize it well. Lastly, this is this new tiny gauge vitrectomy that we now have. If you remember those old videos where I showed those rings being sewn on, we don't have to do that anymore. This, in one shot, we just push in this little cannula, and then this is the fluid that we put in, so that everything that will be cut out will be replaced with this little hose of fluid going in. And then we'll put two more little incisions like this into the eye. One will be for a light pipe, because the way we do these vitrectomies is the whole room is dark, but the eyeball is lit up from inside. So in there we'll put a light, and in here is where that cutting instrument will be put in. So there's three things. One puts the fluid, one puts the light, and one puts the cutter. And then at different portions of the operation we can replace the cutter with various types of scissors and lasers and other instruments as they're needed. But what has really changed is we used to have to open up all these surface structures in the eye. We had to make incisions that were more than twice the size of this, and at the end repair them with stitches. Now, not only did it take about 5 seconds to put all these things in, at the end of the operation we just pull them out, and the incisions are so small they just seal on their own. And that's what makes for the recovery to be so much more